Welcome everybody to this endowment lecture, which is known as Professor Mayadev Memorial Lectureship. It was initiated at the Asiatic Society at the instance of Dr. Suhita Guho, sister of Professor Mayadev, and it was introduced in the field of psychological or social problems of the downtrodden Indian rural women, basically. And since inception, the other awardees so far were Professor Nilanjana Sannal, Professor Indrani Mukherjee, Dr. Pushpa Misro, Professor Anjali Rai. And this year, the lecture is being delivered by Professor Meena Hariharan. And she has chosen the topic Cardiac Health of Indian Women, Biopsychosocial Intervention. Professor Hariharan is professor of the Center for Health Psychology, University of Hyderabad, and also the founder director of this center. She has been working in the area of behavioral cardiology for more than a decade. Her work mainly concentrates on patients with hypertension and those who have undergone coronary artery bypass grafting, CABG. Apart from behavioral cardiology, Professor Hariharan is sensitive to the changing socio-cultural scenario in the country and its impact on family relationships. Professor Hariharan has published nearly 100 research articles and 3 books. She has completed several projects funded by national and international funding agencies. She is the editor of the Journal of Health Studies published by the association. So, with this brief introduction, may I now request Professor Hariharan to please deliver this memorial lecture. Thank you very, very much. Professor Hariharan, please.
Namaskar. I feel quite honored and privileged to receive Mayadev Memorial Award from prestigious organization Asiatic Society for the year 2020. Today we will be talking about the cardiac health of India and particularly Indian women. Indian women are known to be thinking from their heart and acting from their heart. Indian citizens are known to have large heart. That is excellent to be happy about. However, it is about time that we focus on the cardiac health of the country. We need to focus about the heart of the nation. Yes, what I am referring to is the cardiac health of India as the nation. There are quite a few reasons for this. And I wish to organize my talk in two parts. In part 1, I will be talking about the cardiac health status of India with a specific focus on women's cardiac health. And in my second part, I will be talking about psychosocial interventions for enhancing cardiac health of the nation. And here we go. Now, India's cardiac health is at an alarming state, and all of us, the medical professionals, psychologists, social workers, and the policy makers need to divert our attention for enhancing the cardiac health. The statistics speak about the fact of the deteriorating cardiac health of the nation. We'll see that in India, the non-communicable diseases called NCD, which includes cardiovascular problems, respiratory problems, digestive problems, renal problems, reproductive problems, and many other such problems, they account for 53% of deaths in total. 53% of deaths for a population that we have in India is quite a lot. And what is more alarming is, out of this, 24% of deaths are due to cardiovascular diseases. When I say cardiovascular diseases, I refer to the heart as an organ and circulatory system as a whole. People suffering from cardiovascular diseases are on the increase progressively in our country. And when I compare the statistics of India with that of the global average, it rings an alarm again. We see that the world's global burden of disease due to CVD or cardiovascular diseases is 235 per 1 lakh. But when you look at India, the number is quite large and quite higher than the global average. The number comes to 272 per 1 lakh, which is considered to be very high compared to the global average. Let us focus a little on women's cardiac health. There has been a rapid increase in ischemic heart diseases called IHD in Indian women. IHD used to be known as middle-aged men's disease in 1970s. But now this has changed. This is no more a middle-aged men's disease, but this is an elderly women's disease in 21st century. Does that ring an alarm? Yes, this definitely gives us a suggestion that women are now more prone to ischemic heart diseases, and that too the elderly women. So IHD mortality, you will be surprised to know that IHD or ischemic heart disease mortality increased by 93.7% between the years 2000 and 2017 only for women. This talks about almost 100% increase in ischemic heart diseases among women. Why does this happen? What are the reasons for this? One of the reasons is when IHD or CVD used to be known as middle-aged men's disease, the main focus of any rehabilitation used to be helping the middle-aged men in their productive age to return back to their work. That was true in 1970s when men used to be the sole breadwinners of the families. However, that is no more the case. And I would say that this is a sort of middle class concept. Right from 1970s, right from post-independent era, in India, particularly rural women have been equal participants in contributing to families' economy. And from 1980s onwards, even in middle class families, we find that women have been equal partners in contributing to families' economy. So now the focus has to shift from the men to be helped to return to work, and equal importance will have to be given to women patients too. The neglect of women, the priority for men over women in the treatment process, in therapeutic interventions are evident in certain subtle examples which are very rarely surveyed. A survey result found out that prescription of aspirins, ACE inhibitors, statins were found to be much lesser for women patients compared to men patients. Why so? So these are very subtle discrimination that are being practiced in biomedical approach. And another statistical figure which alarms us, which startles us really, is that we see that quite a number of children have been diagnosed with congenital heart diseases. And it is very, very sad to notice that only 44% of girl children diagnosed with congenital heart diseases receive their surgery in their first year of age, compared to 70% of boys. The reason? People are worried that one should not reveal the heart diseases of girl children so that it impacts negatively the prospects of their matrimony. Sometimes it looks ridiculous too. Healthcare intervention should be the same for both the gender. And what are the reasons of this gender disparity? And one should pay a little bit of attention to these psychosocial reasons. The first reason is that Indian women's health correlated highly with socio-economic status and particularly the level of education. And the second part of it is the health belief model. We see that the prevailing health belief, it attributes that cardiovascular diseases are men's diseases, and therefore even though women have certain symptoms and they manifest certain symptoms, they do not attract as much attention as the symptoms in men. The third point is the cost of private health care. We find that in India, the healthcare delivery is highly privatized and it is quite expensive. So when it comes to expenditure on health, it is the age-old cultural belief that men's health should receive priority over women's health. And the other fact that we all must endorse is, whenever it is a question of women's health, the entire focus has been on maternal health, and it has never been any other area of women's health as much as maternal health. And the final point which should catch the attention of all of us is that Indian women's health literacy and awareness about the health status and various aspects of health and knowledge is much lower compared to their men counterpart. Now, we all understand that this is the health status. This is the cardiac health status of India in general and Indian women in particular. What has to be done? Do we just look at the statistics and feel sorry about it? But the statistics are meant for triggering action at various levels, starting from policy levels to bring about some public health awareness program to individual level, where focus is now changed to health for all rather than health for only the productive middle-aged men. Now, what is it that we need to do and what is it that we have to do? The first and foremost thing is it has to be taken as a holistic approach. Cardiac health is no more the prerogative of biomedical team. Cardiac health involves lifestyle and certain health behavior, help-seeking behavior, stopping and prevention of health risk behavior, which involves the behavioral aspects of human being. Therefore, it is very essential that health psychologists also get involved in planning and designing health interventions. Here I would like to present some of the cardiac healthcare interventions that I and my team of research scholars have come up with and which have proved quite effective on Indian population. I will be here talking about 4 salient studies that have proved to be effective both in management of cardiac problem, and we are also planning certain preventive measures for cardiac issues among men and women of India. The emphasis that we lay is that whatever be the intervention should have equal emphasis for men and women because cardiac problem does not know the gender. Let us now have a look at these intervention modules. Now I am coming to explain study 1, which talks about the quality of communication between the doctor and the patient for effective management of hypertension. We have taken hypertension as the basic level intervention because hypertension has been found to lead to a number of cardiac diseases. So managing hypertension definitely is going to help us in managing a number of cardiac diseases. The principle involved here is when there is a good communication between the doctor and the patient, the information that the doctor gives to the patient constitutes a solid knowledge level, and this knowledge level is going to lay a good cognitive base. And we all know about the relationship between cognition, emotion, motivation and then behavior. So that is what I am going to follow, and that is the principle on which this particular study was based. So when you lay a good cognition about the normal circulatory system and what happens when an individual suffers from hypertension and what role does a medication play, why one should follow a particular prescribed diet, why one should follow regular exercise and why one should monitor one's blood pressure levels and consult the doctor. If the patients are explained these aspects clearly by the doctor, then the patient has the cognitive base. This cognitive base triggers the emotion, a little bit of fear, which will be useful in creating a motivation for good adherence behavior. When I am talking about adherence behavior, adherence to the prescribed lifestyle, which includes not only taking the medication on time, but also following the diet regimen, exercise regimen, and understanding and responding to certain alarm signals that your cardiac system creates or triggers, so that it would prevent untoward serious adverse effects. Once this is done, the management of hypertension and the cardiac illness will be much easier for anybody. So, here we are talking about the behavioral management, which has its roots in cognitive base, appropriate emotional trigger, and invoking the emotions as well as the motivation to initiate and sustain the cardiac appropriate behavior. So, this talks about the compliance. In this particular study, we had a group of 30 doctors and 300 patients. One doctor and 10 patients created a nest. And what did we do? We followed up these doctor-patient diet for several weeks, and we studied the communication patterns between the doctor and the patient. Whether the doctor explained every aspect of hypertension to the patient, and whether the patient understood this communication the way it was intended to be understood by the doctor. And accordingly, we divided them into 3 groups: the high quality communication group, moderate quality communication group, and the low quality communication group. What did we find? We measured the blood pressure levels of these patients at the beginning of our study, and we continued to measure their blood pressure levels intermittently till the termination of the study. What we found was, those patients who had high quality communication between themselves and the doctors, the blood pressure levels fell significantly and the hypertension was managed excellently by this group compared to the low quality communication group. And then we tried to track the pathway. The pathway that we could track was, high quality communication contributed to high levels of clinical adherence by the patients, and high quality of clinical adherence contributed to good prognosis. Apart from that, high quality communication between the doctor and the patient also established an excellent rapport between the doctor and the patient, and they directly communicated to a good prognosis among the patient. All that we needed here was a little bit of time from the doctor, who would take into consideration the holistic aspects of the patients, which includes the cognitive level, personality, emotions, and came down to the level of the patient and then explained all the aspects related to hypertension in a language that the patient understood. 5 minutes of time from the doctor could save lot of patients from things like stroke, heart failure, and cardiac arrest. Now, let me talk about the second study. Once we were encouraged about the quality of communication, we thought that more often than not, the cardiologists in our country may not be able to spend so much time with each patient. So, what if we try out on a group communication? So, in our second study, which I did along with Andrew, here we designed a study with about 250 patients diagnosed with primary hypertension. And this group of 250 patients were divided into 5 subgroups. The first subgroup was exposed to a knowledge intervention by a physician who was physically present with the group of 50 patients, explained to them all about the cardiac system and the problem that is created in the system by high blood pressure and the way the medication works in dilating the blood vessels and the way the beta blockers functioned and why one should be very regular with medication, diet and also exercise. And there was an interaction between the group of patients and the doctor. And here again we subdivided this group into two. The first group got 2 exposures with a gap of 2 weeks, whereas the second group had only a single exposure. Then the third group received the same information through a video recording where the same doctor explained the same contents to the group. And the fourth group received the same video exposure only once, while the third group had 2 video exposures within the gap of 2 weeks. And the fifth group was a control group which received only standard medical care. And what did we find as our result? We found that the group that received the knowledge exposure directly from the physician twice was the group which reaped the maximum benefit. We measured the blood pressure levels of these patients every week, starting from the time when we started the study, and we followed them up for 6 weeks, and then at the end of the study too. We found that there was a very clear pathway that went from the exposure of 2 times directly by the physician. It contributed to the knowledge level of the patients, and this knowledge level enhanced their self-efficacy. Self-efficacy talks about a feeling in every human being that, oh, I can do it. So when the doctor was explaining to them about the lifestyle that one should follow in order to manage their hypertension effectively, the doctor also instilled a sense of confidence in these patients that it is possible to manage their hypertension by regulating their lifestyle. That enhanced a sense of confidence and self-efficacy, which made these patients believe, yes, I shall be able to do it. And this self-efficacy contributed directly to adherence behavior, and these patients who were not very good in their compliance with medication, diet, exercise and monitoring, they became more compliant, their adherence level increased remarkably, and that resulted in a good hypertension management as prognosis. And apart from that, we also found that in this particular group who had 2 exposures directly from the physician through his physical presence, his talk, his interaction with the patient directly contributed to their enhanced self-efficacy. Here is where the communication from the physician matters a lot in enhancing the confidence levels of people who would take that into consideration and go ahead changing their lifestyle. This was not seen in other groups, particularly the control group. But there was also improvement in the other 3 groups where they had only 1 direct exposure with the physical presence of the physician, and the group which had knowledge exposure through video recording, they had a marginal difference in their blood pressure levels at the termination of the study, and they were significantly better than the control group. What does this indicate? This indicates very clearly that creating a knowledge base among the patients with hypertension will definitely help them to enhance their motivation in enhancing their adherence behavior. And this enhanced adherence behavior would definitely influence a prognosis, which is good. Now, once again, I would like to reiterate that all that is needed to enhance the cardiac health of patients diagnosed with hypertension is a little bit of time where a cognitive base is created. If you are not able to do it individually, let us do it to the patients as a group by building certain support groups among the hypertensive patients. Now I will come to the third study. The third study triggered, this was triggered by a question. Is cognition everything? What about the anxiety and fear that the individual diagnosed with various cardiac problems faces? Do we leave this anxiety and fear and apprehensions unattended? Is it enough if we just work on the cognition of the patients? So, here is a study that we planned on patients who were going for their bypass surgery called coronary artery bypass grafting or CABG. We took a sample of 300 patients. We divided them into 3 groups. One group was exposed to a new intervention module that we designed, and this module is called PACE. PACE is an acronym and it refers to Program for Affective and Cognitive Education. So, group 1, 100 patients who went for elective CABG were exposed to PACE, and this PACE involved the participation of a cardiothoracic surgeon, a health psychologist, and apart from these two, a patient who has successfully recovered from CABG. And this is a 25-minute video program which was presented to the patients a day before they went for CABG. The second group was exposed to guided imagery, a standardized relaxation therapy which would take into consideration the distress that the patient suffers and reduces the distress level that is triggered just before they go for their surgery, any major surgery. And the third group is a control group. PACE had components both for the cognitive base as well as for reducing their anxiety and apprehension. The participation of cardiothoracic surgeon and the health psychologist gave them all the information necessary for a patient to know about how one would feel soon after the surgery, and the participation of the successfully recovered patient would address all the concerns that a patient would have belonging to the emotional dimension. So, in other words, PACE has taken into consideration both the cognitive and also the emotional needs of the patient, whereas the guided imagery took into consideration only the emotional needs of the patient. And the third group is a control group which got only the standard medical care. And then what happened to these patients? We followed up these patients for a period of 8 weeks, and then the results revealed that the patients who were exposed to PACE module as the intervention, they were the one who reaped the maximum benefit. How? The cognitive component as well as the emotional components, they contributed directly and reduced the emotional distress that the patient suffered. And the reduction in emotional distress directly contributed to overall prognosis and their recovery from the post-operative state. And we found that the patients who were exposed to PACE module were ready to go back to work physically as well as mentally 5 weeks earlier than the control group. And another significant aspect of this PACE model is that the module itself directly contributed to prognosis. Whereas in case of the relaxation group, which received guided imagery, the pathway was very clear and it was only one way, where the pathway was the guided imagery worked in reducing the psychological distress, and the psychological distress in turn reduced their trauma and enhanced their recovery. Now, it is very clear from this that when we are treating the patients with cardiac illness, it is necessary that you take the patient as a whole and address not only the physical pain, not only the physical illness or the physical state of the cardiovascular system, but we need to take into consideration the cognitive aspect by enhancing their knowledge level, and we need to address more importantly the distress state of the patient who is going for the major surgery. And once we do that, there are a number of evidences in the past research which proved that people with lower level of distress will recover from the surgical wounds faster, and the incidence of rehospitalization and relapse are much lesser compared to those people who go for the surgery with high level of distress. So once again, what this study proved to us is that you need to treat the patient as a whole. And in all these groups, in all these studies, our patient sample had both men and women in equal number, and this is because we thought that when it is a cardiac problem, when it is a cardiovascular disease, there should not be any gender differences. Both the gender should receive equal treatment when there is an intervention. And the equal treatment proved that in the recovery rate, in the management, there is no gender difference once the intervention is the same. Then, the fourth study that we had has a futuristic perspective. The fourth study was triggered with the projections that we had that the incidence and the prevalence of cardiovascular diseases are going to increase in the next 10 to 20 years, and more than half the adult population of India will have some or the other cardiovascular diseases. Should we take these statistics only for academic purposes, or these statistics are projected to us in order to stimulate us to think about certain ways to prevent this from happening? So with this, we went into a futuristic perspective and we conducted a sort of quasi-experiment taking children as our sample. We took the children, 181 children studying from class 6 to class 9, and we took these children and asked them to inform us if there is any adult hypertensive patients in their family. And those children with one adult member living under the same roof with the diagnosis of hypertension constituted our major sample. And initially, before the beginning of the study, we measured the blood pressure levels of these adults, and then the intervention was not given to the adults, but here the intervention was given to the children. The children were exposed to hypertension knowledge program through a video clipping continuously for 2 settings with a gap of a couple of weeks. And these children were asked whether they would volunteer to work as health monitors for the adult hypertensives in their family. Those children willing to do this were recruited into our sample. What was done was these children were given a diary, a health monitor diary, and they were asked to remind their adult hypertensives in the family to take their medicines regularly. The reminder will go every day, and the children will monitor the diet of these adults. The children would insist on the adult family member doing their exercise regularly. The children were motivated to adapt any method that they would think would be successful with their adult family member. And every weekend, these health monitor diaries were collected from the children, and they were followed up for 6 weeks. And at the end of 6 weeks, the adults were called back and their blood pressures were monitored and recorded. In the meantime, the children were also tested on a number of personality dimensions like frustration tolerance and perseverance, their interpersonal influencing capability, etc. A number of parameters were tested. And then what did we find at the end? We found that those children who monitored their adult hypertensives effectively could bring in a significant drop in the adults' blood pressure levels at the end of the study. Who are these children? Could all the children do that? No. We found that children with certain unique personality characteristics were the ones who could successfully monitor in helping the adults manage their hypertension effectively. What are these personality variables? The first and foremost is the knowledge level. Those children whose knowledge level were high after the exposure to the knowledge intervention, and those children who had a combination of factors like intellectual openness to experience, conscientiousness, perceived ability to influence, tenacity. These are the characteristics of children which contributed to their effective monitoring of the health of the adult hypertensives. And as a result of this monitoring, these adults showed a better adherence to their medication, diet and exercise. And this enhanced adherence brought about a better prognosis in these adult hypertensives. Now, what does this study indicate? Why did we do this study? We did this study mainly because, look, when the projections are cautioning us that the percentage of hypertensives are going to enhance progressively in future, by 2030, then we need to prepare those people who are going to be the adults in 2030. They are the children. So, this particular intervention module brought 2 benefits to the population or the sample included in the study. The first thing is the present hypertensives, the adults who were suffering from high blood pressure were monitored very closely by the children, and this enhanced their hypertension management skill, and this brought down their blood pressure levels and this in fact reduced the risk of their cardiovascular diseases. So that is talking about the present hypertension population. This study also has a benefit for the future hypertensive population, that is the children. Those children in their adolescent stage now are going to be the adults after 2030. And these children already had an exposure to the knowledge base about the lifestyle, health risk behavior and health promoting behavior, which would work as a very good preventive measure from hypertension. This knowledge level is going to be sustained in these children, and these children, when they grow into adults, are expected to remember these inputs and follow health promoting behavior and not go into health risk behavior. By doing so, we are in fact taking a preventive measure from the statistics going up and showing a higher progressive rate of hypertension in future. So what I mean to say is that we need to work as a team. The doctors, middle level healthcare workers, health psychologists, social workers, educationists, policy makers should come together, and we should work as a team in preventing the national cardiac health from further deterioration. So Indian government has already taken certain measures for promulgation of comprehensive primary health care CVD management guidelines. They have included cardiovascular diseases as one of the important healthcare measures to be taken care of and focused at every level. And then the government also has been advocating that the treatment approach for cardiovascular diseases should no more be limited to biomedical approach. There should be a paradigm shift, and biopsychosocial approach has to be adopted and embraced in handling the cardiovascular diseases among the population of India. Then the preventive steps combined with the management techniques should be the thumb rule, and that should be the mantra that we need to follow. And when we are doing it, there should be large scale public awareness programs, and we should come up with certain modules to create awareness among the population for protecting the cardiovascular health of the individuals. And when we do so, there should be a specific focus on women population, because the statistics and the survey already says that the awareness levels of women are already low. So the public awareness program for cardiovascular diseases should lay a special focus on rural people, women, rural women, and also children. In other words, it should cover all sectors of population of the country, and if there is a need, there should be attempt to come up with certain designs for specific population, specific sector of Indian population, so that the country's health, particularly the country's cardiac health, is taken care of, because we want India's heart to beat in a healthy manner while being large hearted, while thinking from our heart, while behaving through our heart, we should ensure that the heart of India is healthy, and particularly the heart of Indian women, Indian rural women, should be taken care of to keep it healthy for all. Thank you very much.
Thank you, madam, for giving this memorial lecture on Mahadev Memorial Award. The topic of your discussion this afternoon was remarkable indeed. It was cardiac health of India, particularly in the context of the cardiac health of women. You have rightly dwelt upon the general situation of the cardiac health of the country in your address, and you have rightly pointed out that there is the necessity for psychosocial intervention for enhancing cardiac health. It's true that as far as the cardiac health of the population in our country is concerned, the situation is alarming, and some urgent steps need to be taken. As you have rightly pointed out, some urgent steps need to be taken in order to improve the situation. As you have mentioned in your talk, amongst the non-communicable diseases, NCD, as I rightly said, as far as the non-communicable diseases are concerned, 24% of those diseases, which constitute 63% of the total available diseases in our country, 24% of those non-communicable diseases are due to the CVD, and India's position in the global scenario is also not very encouraging, because the cardiac patients in the all India in the global situation, they constitute 235 per 1 lakh population, whereas in the Indian situation they constitute 272 per 1 lakh population. These are the things which you have mentioned in your address, and within this deplorable cardiac health situation in our country, the position of women's cardiac health, ischemic heart diseases, that is still worse. If the general situation is bad, the condition of the cardiac health of women is worse. And earlier, the entire attention used to be given to the cardiac health problem of men, because they constituted the center of attention, the focus of attention. Women were neglected, and there has been another remarkable change in the scenario, in the sense that earlier mostly the middle-aged men were affected by this type of disease, but now it's more elderly women are affected by the disease, and there has been an increase of 93.7%. You have mentioned in your address, there is an increase of by 93.7% in the number and percentage of women cardiac patients in our country between 2000 and 2017. So this is the deplorable condition of the cardiac health status of our country, and within the cardiac health situation, the condition of women are still more deplorable. And rightly you have pointed out that this worsening condition of women is to be tagged with the general scenario where women are neglected in our country. Not only women patients, but the condition of women in our country as such remain neglected. So even as far as the therapeutic aspects are concerned, women seem to be neglected. So this indicates a gender bias in the treatment of the cardiac patients, in the attention given to the cardiac patients, the women patients particularly, and the care and attention which is given by the family members. I mean, in the sense that when a man who was the sole bread-earning person within the family is affected, all attention, including medical attention, seems to be given to him or him. But when women are affected, particularly in the earlier decades, there was less attention given to him, and the medical attention was also very scanty, very inadequate. So there has been a gender bias, and you have, as a psychologist, leading psychologist in our country, you have conducted a number of experiments in order to show that how women tend to be neglected by the doctors and by the family members. In fact, this gender bias is prevalent, is to be found not only in the case of women, I mean patients, women patients, but also in every other situation or phenomenon in our country. If you look at the occupational scenario, mostly the representation of women is neglected, and even if women get appointed, they are appointed in some routine types of jobs which do not require any initiative, innovation, in the sense that it is regarded that women are unfit for such type of innovative work, and so routine types of jobs are assigned to them, or lower levels of the occupational ladder are provided to them, a situation which is sometimes referred to as glass ceiling. That is, beyond a certain point, particularly in the managerial positions in the occupational structure, is very difficult for women to get selected. You have, in your discourse this afternoon, you have pointed out the same scenario existing as far as the women patients are concerned. There has been an all-out neglect of the women patients in the family, at the health care level, and at the level of the outer world of the women patients. So that shows that some additional attention needs to be given in this area, particularly in view of the fact that the number of such cardiac women patients is alarmingly increasing in our country, particularly the elderly women, as far as the elderly women are concerned. So thank you, madam, for providing your attention to this neglected field, henceforth neglected field in the sphere of women's treatment. And you have said that it's not only that inadequate medical attention is given to them, but a host of other source of help, other professionals need to be included, need to be taken into consideration, like for example health workers, psychologists, psychiatrists, like that, because doctors are very busy and they have hardly any time to explain to the women the complicacy of the treatment procedure. So in order to help them, some additional counselors or health workers, if they take that position, then if women are explained clearly the nature of their disease, the nature of the problem, and the nature of the treatment procedure which they have to adopt, then their recovery seems to be quicker. And since the doctors are very busy, and doctors also have a tendency not to explain things to the patients, particularly if the patient is a woman, because they dismiss it. Oh, apni bujhben na, is beyond your comprehension, so that type of attitude. But modern day, it is accepted that if the position is explained clearly to the women, the nature of the complication, the nature of the treatment procedure, then the recovery would be quicker. Their physical condition will quickly adjust themselves to the changed situation, and on the whole it will be helpful for the patients. And for that, a host of other professionals need to be taken in for helping this category. So with your profound scholarship in the area and your experience in conducting researches in the area, you have sufficiently clearly clarified the position to us. Thank you very much for this, and I think those who are listening to this, they will become very much benefited by your erudite presentation. Thank you very much.
Professor Shapal Kumar Pramanik, President Asiatic Society, Dr. S.B. Chakraborty, General Secretary, Asiatic Society, Professor Meena Hariharan, Professor at Center for Health Psychology, University of Hyderabad, and all other persons present in the occasion. I express my heartfelt thanks to all present in the occasion. I particularly extend my thanks to Professor Meena Hariharan for her excellent presentation on cardiac health of Indian women, biopsychological intervention. It was a beautiful presentation, and all present here, we have a beautiful experience on the program. I express my thanks to you all to make the program a successful one. I particularly extend my thanks to the persons of Asiatic Society who made it possible to make the program a successful one. I express my thanks to you all. Thank you very much.